For it's a nice scene-setting introduction. So we'll move straight on to Ian. Thank you.
Thank you. Thank you very much. I'm going to talk a little bit about Nepal. First of all, to follow up on some of the issues that were raised in the first talk here, sort of unregulated markets. But then, specifically, I want to really just raise one point, which is that in a country like Nepal, which has a weak regulatory capacity, as I'll explain, we need to disaggregate what we mean by generic drugs. There are different generic drugs for different types of problems, and sometimes programs and other things can have some regulatory effects, although perhaps not in the way that we understand at this stage. The ESRC DFID funded this, and I should always thank them very much for that. Tracing Pharmaceuticals in South Asia, where Jeffrey was the PI from which the data for this presentation came from. Now, Nepal is seeing an expansion of its pharmaceutical markets, increased sales and consumption. The market, for example, in 2006 was estimated to be about $100 million, with a growth rate of about 16% per annum or more in terms of sales. Now, by far and away, the majority of drugs in this market are branded generics, and these are for common conditions. So these are for infections like antibiotics, painkillers, and so on and so forth. And it's dominated by what Hayden has called little pharma. These are off-patent drugs. And the patented market's very, very small. These are branded by companies and then marketed in the name of the brand rather than a generic form. So to take amoxicillin, there'd be up to 20 different brands in the market, and everybody's doing all sorts of things in order to get their particular brand of amoxicillin to be utilised. Now, this is dominated still by Indian companies. So Nepal's relationship with pharma and markets is absolutely dependent on India, big neighbour. India and the Indian companies perceive Nepal as an unregulated market, one that they can, it's basically seen to be unregulated. Now, by 2010, about 70% of drugs in the market were coming from Indian companies. 30% or so were coming from one of the 45 or so Nepali companies. One of the strategies that that Nepali companies were attempting for this market was forms of capture, regulatory capture, as John has called it, but a very particular national kind. So make sure that the labels are all written in Nepali and so on and so forth. So whenever I would go to the Department of Drug Administration, there'd be representatives from all the Nepali companies, and they're lobbying away for their particular drugs. Now, regulation in Nepal is a problem. I've written on this elsewhere. There have been attempts by the government to regulate. So, for example, in 2007, they released the ethical guidelines that were around marketing drugs. This was an attempt to prevent the prevalent practices at the time of what people spoke to us about as bonusing. That is, if you're a retailer, you buy drugs from my company, I'll give you 100% bonuses if you buy mine rather than the competition's. Bonusing can be 100%, 120%. It varied across companies, but it was significant. Substitution, which is the substituting of the generic drug for the branded form, is another issue. And other marketing practices, like brown envelopes with money, through to I use the term marketing in paying for flights for people to go to conferences and so on, lots of rather unscrupulous practices. And so the Department of Drug Administration produced these guidelines, and they said they wanted to implement it and bring the force of law behind it so that to better regulation. This failed. Completely. They were unable, within weeks of the release of it, they were unable to do anything. Now, what we found is that we have retailers, wholesalers, importers, companies, their representatives, the medical profession, everybody, while they would acknowledge that there were ethical problems and marketing problems, none of them accepted responsibility for it being their problem. It was always the problem of some other group. So when you have a large apparatus of this kind, it's easy to defer kind of responsibility onto someone else. Deferred blame. And the state, through its Department of Drug Administration, here we have a hugely under-resourced department subject to political manipulation in Nepal's very volatile political context, couldn't assert itself in this context. In particular, the retailers and wholesalers, for example, resisted. They threatened strike action to stop the import and distribution of drugs, and quickly, it only requires 1 or 2 deaths as a consequence of this for the government to it rescinded on the implementation of ethical guidelines and couldn't really do anything about it. There are then, so therefore, in terms of state regulation, there are problems. But, and to come to the second and last bit of the talk, if we look at and then sort of issues around generic markets, I think we need to disaggregate to be a little bit more specific. So one of the areas we were looking at was TB drugs. I'm only going to talk about first-line TB drugs. That's they're all off patent. And what we've seen over the years in the context of Nepal is a public health program, a very vertical program called the Direct Observation of Therapy Short Course program that's been implemented in a vertical way, funded initially by DFID and the Japanese, and later through the Global Fund, that has had some degree of success in that cure rates from within those reported within the program. It covers the whole country. They have a very specific set of drug regimens that they recommend. And the way we were able to assess that it had been successful, it always reflects on its own capacities as being highly successful, was we interviewed and talked to, for example, private retailers around hospitals. And we chose a number of those that had DOTS clinics, others that didn't have DOTS clinics. And they reported decreased sales of TB drugs in the context of Kathmandu and a district outside of Kathmandu where we did this research. Some reported that they stopped stocking TB drugs entirely. So private retailers reported significant decreases in the drugs, the TB drugs that they were actually stocking. The second issue that emerged was a change in the types of drugs, TB drugs that were available. So there were more fixed dose combinations available. These are when TB drugs are combined either to 2 drugs, 3 drugs, or even 4 drugs, or strips, where the TB drugs that need to be taken in one particular day are all in a strip. And there were fewer single drugs, uncombined drugs available in the market. So this was a shift that occurred. I'm talking about Nepal here. India is an extremely different situation, which I don't have time to go into. The third issue was a change in the company profiles of who was actually involved in producing, in marketing, producing these drugs. What had happened was that the local production of Nepal's anti-TB drugs had completely, the bottom had fallen out of the market, and all Nepal's companies had stopped producing drugs. I won't go into the specifics of it, but basically the market, in the wake of the disappearing market and the rise of fixed dose combinations and strips, they found themselves way behind the game. So that was one issue. Another issue was the question of quality.
It's okay.
All right.
2 minutes.
You're
just under 2 minutes.
Was changes around when the WHO announced in 2004 that 4-dose fixed combination drugs, for example, were one way that countries could now deal in. They just didn't have the capacity to kind of make these things. A number of companies did, and they were Indian companies. So what's happened is that there are a few Indian companies that now dominate the market in the context of Nepal. And this is again a shift that has occurred over the sort of last 10 years or so. Lupin is the highest. Now Lupin and McLeod's was the second highest, and there's a third company called Concept. There were 1 or 2 smaller ones, but they were the main producers of TB drugs. These are also pre-qualified suppliers for the WHO through the Global Drug Facility. So these are companies that produce the centrally, globally procured drugs for national TB programs, part of the Global Fund funding. So fewer companies, they're Indian, and the types of drugs, a combination of drugs being produced have shifted to fixed dose combinations. Now, this is from a public health perspective, a definite. It's a better situation to be in than in India, for example, where there are many, many different types of TB drugs marketed, produced by 40, 50 different companies in all kinds of different combinations. And doctors would complain about the lack of availability of single rifampicin. They couldn't find it. So while there was some the market availability drugs was restricting private practitioners' ability to practice what was available because it was more in combined form, there'd be less likely for there to be the rise of MDR, TB, and I haven't got time to talk about MDR, but I could do, but I'll stop. Thank you.